and the ultimate men's movement with our host, Dr. Jack Rocco. Dr. Jack, you've been going solo a couple weeks. Okay? We're getting busier and busier. But again, that's where I hand the baton off to
You took
some great co-host for the Neil Haley Show. So you have to put that on your resume. You're on the co-host the Neil Haley Show and host your own podcast. That's impressive stuff.
You took the training wheels off, and I stumbled a little bit, but no major falls on my face.
Awesome. I know you always are out there researching to find amazing guests. Who do we have today?
Yeah, this is Todd Otten. Otten or Otten?
Otten.
Otten. Yeah, Todd Otten. Todd is a family practice physician in Michigan. And I came across him once again through the author connection. He has a book out called Ripple of Change. And there's a little group of us, of physician authors online, who've been connecting and chatting back and forth. And Todd is a little specialer, in that in addition to the book, he also has a documentary that he's working on in conjunction with that. So the book is Ripple of Change, and the documentary is called Suck It Up, Buttercup. Is this true, Todd?
That is both are correct on both fronts, sir.
Excellent. Now, when I start seeing these topics, I get a little bit of that flashback Vietnam, residency, and healthcare triggers. It's always nice to hear my fears and my anxieties of healthcare confirmed by someone else, but it's always nice to hear different perspectives. So I'm going to let you further introduce yourself however you like, and then we'll start getting into some of the topics that you cover.
Yeah, for sure. I'm not going to read my CV, but I'll give you the short version of who I am. So yeah, family physician. I thought I wanted to be a trauma surgeon back in the day. Actually did a year of general surgery before the 80-hour work week was instituted. So you can imagine, Jack, you could really appreciate how much I was truly in the hospital during that time. Fast forward, a few decades, many gray hairs, so on and so forth. Been through burnout, told my toxic employer where they could take my job and shove it, to now we're working on the documentary, Suck It Up, Buttercup. And I think we'll start there because you alluded to a little bit of what I think is some of the genius of the title. And I take no credit for the title. That was actually our creative group that came up with that. But the comment, Suck It Up, Buttercup, kept coming up, whether it was from clinicians who, as you alluded to, the trauma and residency and really that intergenerational trauma that exists being passed on from one generation to the next. It came up from administrators and it's some interesting facets. But if you think about the landscape now, ultimately, we're telling that to patients. Like oftentimes they're given a diagnosis and 20 pages of gobbledygook, and that they're supposed to then navigate the waters. And it's, hey, good luck, suck it up, Buttercup. Good luck getting to the specialist or finding how to get your treatment or navigating a prior auth or all these other kinds of things. So I think the title is very apropos, and it's interesting because it's a little bit polarizing. I would say about 80% of people love it and 20% of people hate it. But I guess that's what you want. You want them to remember it. And I think we've come to that.
Yeah.
You don't know. So what I think about that, you're right. You're going to have people that don't like what you do. And then other people are going to be just so into it. I think when you become so toxic that everyone doesn't like what you're doing, yeah, you might be getting a lot of clicks and people are excited, but they hate you. At least you have good feedback of the people who enjoy it.
Yeah. Yeah. The thing about the title is, how many times you've heard that during residency? We didn't even have that option to consider not sucking it up back in the day. You signed up for this, and if you don't like it, you can leave. You're right. I'm older. So I went through the 120-hour work week was pretty much average. 143 was my most hours in a week, and 84 hours straight at the VA was my longest straight one shift. And it was my first month out of medical school, my first month in internship. I got stuck up at the VA in Wilkes-Barre, Pennsylvania for an 84-hour shift. Now, can you imagine? That's just trial by fire. And starting in July, and sink or swim. That was the way that it worked. What about you? What year did you? I started my first year of residency in '89. It's 92. 92 is my first year of residency. When did you start?
2002. So I was a decade behind, and I only had the pleasure of 1 year being with no restrictions on work hours. And so I think my personal record was 126 hours in a given week I was in the hospital. And if you think about it, I think there's only 148 hours in a given week. So when you say you were there 143, I'm like, oh my God,
168.
168. Okay. Math's
Yeah.
off a little bit today. Forgive me for that. It's early. But even then, like, you're only home for 20 some hours. Like, where's your
Yeah.
time to recharge your battery?
How do you have a life? How do you have a life? I'm going to just jump in on this, Jack, during
Yeah.
this conversation, because I'm an entrepreneur. I'm building something where, yeah, I'm at 100 to 104. And I honestly tell you, if I would give entrepreneurs advice at 52 years old, please don't get into a relationship till you make it. And this is hard. And you're thinking about in the whole medical school side of things, at least you guys get to a certain level earlier. An entrepreneur might be grinding it out for 25 years till they finally get there. That many hours. And the health research is out there that if you work that many hours, you're hurting your life.
Oh, absolutely. And that's you mentioned earlier, Todd, you said burnout. And I know a lot of people are changing the language of that to represent moral injury. You'll hear a lot of people talk about that. And you're right. I think they are two different things. During the 143-hour work week, and that was up at Fox Chase in Philly, and it was about a 45-minute drive. So I was leaving sometimes 8 o'clock at night, 9 o'clock at night, 45-minute drive. You'd sleep for a couple hours at home, but at least you were in your own bed. And then waking up at 4 a.m, doing another 45-minute drive back to the hospital. So that, is absolute fatigue. And but even as they've diminished the work week, they've also got, like I said, this idea of moral injury where you really can't do your job. Do you want to talk about that, Todd? The differences, how you look into them?
Yeah, 100%. And you're right. I think they both exist, burnout and moral injury, and definitely they're distinct entities. Interestingly enough, the first, I would say, key interview that we had for the documentary was with Wendy Dean, who I've gotten to know, and actually they're part of the cohort of organizations that are now supporting the project, which, of course, I'm digressing myself again, but there's 50 to 60 orgs supporting the documentary. But moral injury, simply put, it's kind of like death by 1,000 cuts. What you're trying to accomplish for a patient is being blocked by just obstacle after obstacle, prior authorizations, insurance restrictions, time restrictions, financial restrictions. And when you can't do what you want to in an ethical fashion, that in and of itself is an injury and connotes moral injury. So moral injury is more emblematic of the systematic issues that we have. Whereas burnout, the way I see burnout, that's that anger, lack of empathy, compassion fatigue, et cetera, that an individual experiences when their resiliency is being tested to the limits, if you will. And having experienced that personally, it's painful. And I talk about this a lot, to go from a job that you love, that you absolutely love and cherish, caring for other human beings, to viscerally hating it. I remember sitting in my backyard in tears, not wanting to go to work anymore because I hated the job that I had always loved. That's burnout. So I'm paraphrasing a bit, but yeah, they both exist. And I see moral injury very emblematic of our systemic issues, resulting in burnout for individuals when they just can't take it anymore.
And Dr. Jack, when that happens, then you're not going to be able to serve the patient the right way. You're not going to be able to provide care, and you're going to become a machine versus a human being and a human relationship of patient care.
Yeah. Like I said, on the burnout side of things, you're not sleeping, you're eating poorly. At the VA, I remember we used to get these little styrofoam boxes with a hot dog and some overcooked fries, just poor nutrition, poor sleep, just chronic stress. So then some of the things that I've seen, physicians misbehaving, and it's one of those things that everyone likes to point the finger at the physician. And I remember one of the funniest or saddest occurrences was there was a neurosurgery resident that he was a year older than me, a year above me. And at some point he was a PG3, and the PG4, they had 2 per year. The PG4 was in drug rehab, and the PG5s, both of those spots had quit. So this guy was a PG3 working as a chief resident. And one night in the cafeteria, he's looking at the food menus. He's looking around. He's like, yeah, none of this looks any good to me. He told the cashier or the cafeteria worker, can you make me a peanut butter and jelly sandwich? Can I just make me a peanut butter and jelly sandwich? And she's, I can't do that. We don't have that on the menu. He's like, what do you mean you don't have it on the menu? She's like, I wouldn't know how much to charge you for it. He's like, it doesn't matter. I don't pay for it anyways. I've got voucher cards for my food. So we still got to ring it up. And she would not make him a peanut butter and jelly. He goes, you have peanut butter, you have jelly. I know you have bread. And she would not make him a peanut butter and jelly sandwich. So you see this neurosurgeon flipping his shit.
Just over peanut butter and jelly.
Over a peanut butter and jelly sandwich. But you get to that point in time where the dude was starving. He was stressed. He just wanted a peanut butter and jelly sandwich. He didn't want the mystery meat that they were serving. And I said, you look at it and it's, in one sense, it's funny to think about, but horribly sad. That's the poor guy can't even get something like that. Do you have any stories like that, Todd?
Oh my God. I was trying to think.
Yeah.
I was trying to think of which one to piggyback on here. You think about the box clicking and all the other things that occur. Oh my gosh. So I'll give you a story related to that. So when I was at nearing the breaking point of my personal journey through burnout, I had two charts that were open, and literally they both needed one box to be clicked by a medical assistant. I literally couldn't close the charts. I timed how long it took for this to be accomplished. I think it was 60 seconds or something. As a result of two charts being open on the quote unquote day of reckoning, if you will, I had $3,000 of pay withheld because I had two incomplete charts. That's insanity. That's on the same level as not being able to make a peanut butter and jelly sandwich because you don't have the button to click. And you hear these stories and they go on and on and on. And I'd like to take it maybe even a little bit another level, if you will. Imagine you're a patient. 50% of clinicians, particularly physicians, are burned out, plus or minus, right? So there's a 50-50 chance that the person you're sitting across from that you want to get care from is not at their best. And all the studies show when they're not at their best, it costs more, quality goes down, outcomes are worse, et cetera. We are at a time in healthcare where these issues are pervasive, and we have got to move the needle the other way, which is why having these conversations are so critically important. And I did forget to say one thing. Thanks for your service, Jack. I totally forgot to say that. I appreciate you, sir.
Thank you. Thank you. I appreciate that. Yeah.
All right.
So, now, we've also gone through a change in the click burnout, click fatigue with the advent of electronic medical records. I think that's been a big source of moral injury and or burnout. When I was in private practice in Pennsylvania, I remember going home, you always had 30, 40 charts that were in the queue that you'd finish a day of work. I would run to my kids' soccer event or performance event at the end of the day. And you're standing on the sidelines of a soccer game in your shirt and tie. Then you go home, you grab something to eat, and then you assume your position on the couch to finish your day's charts. It becomes a never-ending duty with the electronic medical records and the detail that they require. And most of it is, you could look at a chart and there might be 8, 10, 12, 15 pages, and there's really only 2 or 3 paragraphs that's clinically relevant. How has that affected you in your day-to-day life?
Oh, you get a couple threads go through my mind when you say that. One, wow, for the audience, that time that Jack's alluding to on the couch in the position that he's assumed, that's called pajama time. That's the time that's uncompensated for clinicians to finish their work. And for many out there, that's multiple hours a day that you're doing this. It's not only, it's taking away from family, right? It's insane. So when I went through burnout, I did a retrospective calculation of how many clicks it took me before I got burned out. There were some assumptions made in there, so on and so forth. But any guess to the number of clicks? So over a 17-year period, how many clicks do you guys think it was before I got burned out? Any idea?
Can I give you, I would say, how many clicks?
Yeah.
2,500.
No. Oh my gosh. That's like per day.
Oh, that's per day. So See, I don't know this world. This is the funny thing, Dr. Jack, is I get thrown in all these conversations, learning all these professions that I have no idea about, that people aren't able to share. And it's so
Well,
you're sharing this information.
You're talking cumulative over, would you say, 17 years?
Cumulative. Oh, yeah.
Oh,
Yeah.
okay,
So
like a million?
you're getting closer. You're getting closer. I'll give you the answer in just a second. So I actually counted how many clicks it took me to fill a controlled substance one time for somebody. I don't even remember what it was for. That took 27 clicks. So it was just shy of 18 million clicks before I burned out.
Wow.
You think about that. It's like you have your educated, high compensated individuals doing clerical work. And why? For billing. We've created a machine that essentially is.
Why wouldn't the billing team do that? Because you have to sign off on it.
You're the billing team.
Without going down a rabbit hole, ultimately, most of this has been, all these burdens have been pushed onto physicians and or other clinicians because we've been taught to be more resilient, work harder. What color straw do you want to suck it up, Buttercup? But all those kinds of things. And to go further, I remember reading a note. It was a post-operative note, Jack. I think it was 17 pages long. And literally, I was looking for the one sentence that said, patient is doing well, no complications. 17 pages of crap for me to find literally about 10 words.
Yeah. Oh, so many times people come in through the emergency room. And once again, you pick up a stack of charts. And I'm from the day, some of the giants that I trained with, John Lockman, the Lockman exam with orthopedics. You'd pick up a chart that he did back in the day at Shriners, and there'd be all these giants of orthopedics, and it'd be like doing well, as above, improving. Like those were the notes.
Yeah.
My aunt was a patient at the Shriners Hospital in the 40s, I think it was in the 40s. She was 10 years old. She developed polio. And she had an 18-month hospital stay, and her entire medical record was 3 pages long. That's not even your intro. And these guys were fantastic. They were the giants. And now someone will come in and it's 10, 12, 15 pages from an emergency room visit, and you can't find that they sprained their ankle. You can't find on the chart, your surgeon said, ankle sprain. Okay. And it's just the wasted time that it spends doing that goes in. You could talk for days on the whole burnout, and you're a smart individual. You finished top of your class. You've gone through 4 years of college, 4 years of medical school, 5 years of residency. And then you're expected to do all these mundane tasks that you don't even get to utilize a lot of your training and your higher skills, not even to mention compassion. By the time you get through that, where's the compassion for that? So it's endlessly, and it's very hard to find anyone. And the recommendations, a lot of the administration, you need to establish a work-life balance. You need to do some aromatherapy, learn to meditate. Are you kidding me? How about make the system better?
I really want to jump into this, Todd. So what was the response when this book has come out? What have you gotten from the medical community? I'm just interested in this because, again, this is really something that now I'm going to think of medical professionals in a little bit of a different light than sometimes because there's a lot of people gaslighting medical professionals now. Jack, I'm just telling you, this is what's happening. And it's because of the evolution of certain new things and thinking they're know-it-alls. And it used to be Google search your diagnosis now, or WebMD and all these things. Now it's AI and all these different things that they're saying, hey, these medical professionals are lazy. They're overpaid, all these different things. I'm so glad you've written this book to show that, you know what? You work your ass off, period. And you're not paid for, you're paid for what you're getting paid well. But ultimately, you're giving up your entire life to serve others. And it's just not out there. And I think it needs to be.
Yeah, I think you make a great point, Neil. And we actually touch on this quite a bit in the documentary. Some of the backstory of, in particular, becoming a physician. You think about, Jack just talked about the time in college and then medical school and residency. And if you go on for a fellowship, you're giving up 15 years plus or minus of the prime of your life. Your 20s and your 30s in devotion to serve others. That's just one component of it. The other component of, and Jack and I are in a little bit different boat because we were in the service, but the average medical debt's plus or minus $250,000. So and that doesn't count college debt. So, you've got individuals coming out with potentially $500,000 of debt. And so they've got golden handcuffs when they're into these jobs. And then you put all these obstacles in front of them to providing care. So back to your question, I think ultimately what I was trying to do with the book was to open people's eyes,
Right.
and ultimately open people's hearts as to the reality of what's really going on. And the response from clinicians is, "Oh, I'm so glad you wrote this. I'm glad you had the courage to share your story. I don't feel alone anymore." And really, we were trying to empower and inspire the people. I think what's more interesting is when you talk to people that aren't in healthcare and they read it and they're like, for example, I've had 4 of my colleagues die by suicide in my career, and people are like, "Wait, what?" And I'm like, "Do you know that we lose about a doctor a day in this country to suicide?" It's appalling. And it speaks to all these things that people, their cup gets emptied and they're so desperate to escape some of these issues that they see that's their only way out. Or Jack talked about the neurosurgeon that was in rehab. The substance abuse that occurs is problematic as well. And so the country needs to be aware of this and the fact that our people that are wanting to serve others are struggling.
Yeah.
And struggling big time. And we need help. We need the patient's voice to be in conjunction with ours to really move the needle. And that's where we're going with the documentary.
But I think the book and the documentary, especially, definitely you'll have lots of medical professionals, but there's going to be a lot of blowback as well. I'm surprised there hasn't been enough. If you would go on social media and talk about this, woe is me as a doctor, it would be interesting to see what TikTok would do, even though TikTok's, as I know, is going to be M2 as of tomorrow. I'm waiting to hear what happens on that whole process. They're not saying anything. And just basically getting that story out there for people to understand. Because, man, I went through this as a teacher. You guys you're overpaid as teachers. Excuse me? We take our work home with us. At 3:00, we're not done. We're doing paperwork for freaking 4, 5, 6 hours. And if you're a good teacher, you're checking papers every day and working till 9:00 at night. And so you have your summers off. No, we're prepping for the next year. And then the same thing when I was working as in therapy. Same deal. It's, excuse me. So I think that this story needs to be out here because we need to look at work-life balance, but we also got to look at specifically enough mental health and then really address mental health for everyone, not just because you're successful. You went to medical school. You're successful at what you do. Those people are fine. We don't need to work with them. They don't have any issues. They're successful people. You know what? They don't have problems. And Dr. Jack, that's the thing also needs to go out there is the most successful people are professions, doctors, lawyers, top consultant engineers, or entrepreneurs that are doing really well. They're going through a lot of stressors to get to where they are. And I think that needs to come out more.
Yeah. And it's definitely more lonely at the top. Go ahead, Todd. What do you say?
I was going to say, you made so many amazing points. Ironically, I'm sitting across from my buddy who's a teacher. And as soon as you started talking, Neil, his head popped up and his glasses went up. Whoa. But I wanted to say back to the documentary, it's not about woe is me. And we're very cognizant of that because we don't want to paint the picture that we don't want it to be a pity party. We want people to see the reality of what's going on. So we're anticipating 3 story arcs. One will be the physician, and the sizzle reel's physician heavy. Who do you reach out to when you start a project? You reach out to your friends. And as a physician, my inner circle is going to be friends. But we have a very powerful nursing story arc that's going to be woven in there of a nurse who was assaulted while doing triage in the ER and stabbed 3 times with a butcher knife, including the external carotid artery. The only reason she's still alive, I won't get into it. But we're also going to have the patient arc in there too, Neil. And by weaving those 3 together, I think what we're trying to do is come up with a magic sauce so that it speaks to the vast majority of individuals with the underlying tenet of how greed is destroying our system.
100%.
Todd, you talk about your quadruple aim. I see that in your writings. Now, what are your recommendations for improving the system? What do you see as some of the ways to change things, that ripple of change?
Jack, I think you said this was only an hour, not a week-long podcast. So I'll try and keep the answers
You're
short.
doing great. You're doing great with the short answers. We're only at a half hour.
Yeah.
I'll be able to cover this because my time, I'm enjoying this conversation. And Dr. Jack, thank you again for finding this guest because
Oh,
this
yeah.
is so important. It's going to be so highlighted on the Neil Haley show that these things are out there. I want to go into that patient arc a little bit more, but because I really think that what are we going to do to transform healthcare? Bottom line is, and this is an interesting, I was hearing conversations. I don't use all the healthcare that's available for me. I have private doctors I work with. I guess one that's right on this line. I want to do everything to value my health even more than everything because I can't trust our current health system. And I'm glad that's part of this process too.
Well, I think there's probably multiple layers to try and answer this question. I'll go back to the first part of this, which was the quadruple aim. So the quadruple aim was an evolution of the triple aim, which Don Berwick, who is part of the documentary, and we interviewed him and I was transformed to like nerd heaven the day I got to interview him. I had him sign my laptop. I was so excited. And he got a big, excuse my language, shit-eating grin when I did that. But anyways, it's around population health and patient outcomes, better experience and lower costs. That's the triple aim. The issue with the triple aim, in my opinion, and many others, was there really wasn't any focus on those providing the care. And ultimately, it led to an increase in clerical burdens, box clicking, obstacles, et cetera, despite the fact that the impetus was to improve things. In 2014, I believe it was Dr. Sinski and Dr. Bodenheimer suggested a fourth component to the triple aim, which was essentially clinician wellness, paying attention to those providing care and making sure that they are well. In Ripple of Change, we took a little bit of a different spin on it. We called it our quadruple aim. So it's not mine. It's not Jack's. It's not my co-authors. It's not Neil's. It's anybody's. Take it, run with it. And it's intended to be a framework or a lens when you're making decisions in the healthcare space that you pay attention to patient experience, the quality of care, the cost of care, but also the provider or clinician wellness. And frankly, when you do that, the vast majority of stakeholders win. I have seen this work at multiple levels, whether it was at the critical access hospital, the office level, the ACO level. You know, the patients, they know when things are going well, they want to be there. And guess what follows when that happens? Dollars, which sustain the whole thing. So that's just one mechanism for improving care. I think we could talk about it at the individual level. We could talk about the system level. We could talk about policy. There's all kinds of rabbit holes here. Ultimately, it's not just going to be one thing that is a quick fix, but this framework, if you take it and utilize it, it works. It really does work.
Now, Todd, I have a little bit of a conspiracy theory bent on some of the cost savings. And if you look at a map of the country and over the last 30 years, if you looked at what the main industry was in many of the different states, you've got manufacturing, you've got farming, you've got technology. And now the predominance of industries across the country are all healthcare. Most states, healthcare is the number one industry. People say healthcare is thriving. That's great. Is it? Or is it that everything else is failing? I'm in Erie, Pennsylvania right now. Manufacturing is down. There's no jobs for that. So everyone's going into nursing and healthcare. But, you know, from the government standpoint, as a former military guy, it's all about the economy, stupid. That if the economy tumbles, if you save 20% on healthcare, what a dig in the GDP that would be across the country. And then America's bond ratings go down. So I do wonder sometimes, do the powers that be, do they want to save money or do they want to keep elevating it so that it looks as though the economy is growing? What are your thoughts on that?
Oh, wow. I think those that are winning in the current healthcare game, if you will, are very happy with the status quo. There are many that are getting very wealthy on what's going on. But I think ultimately I would make the case that we are not in a healthcare system. We are in a sick care system or an illness care system. And frankly, the vast majority of people, meaning the 300 million plus people who are frustrated, are not thriving. We spend twice the amount of money or more than other developed countries, and our outcomes, frankly, suck. They suck. Our life expectancy is currently going down. And you look at our mortality rates in maternity, we're terrible.
But and it also has to do with because nursing homes make tons of money. You look at areas where you get sick, that's where these other people thrive off this. Meaning, well, and then I swear it's interesting, Dr. Jack. I never thought of this. I could potentially be working with a pharmaceutical company with a specific person that had HPV. It's just weird how you look at this, but it's again where the money goes and where that money trail goes and what is going to be the next phase. And if it's about money, it's politics too. So this can't just be a patient doctor administration movement. It has to be a political movement as well, where literally you have to go to your politicians and say, we need this to change. And so I'm going to put this question and hear what Jack has to say after what Todd said. Todd, when you said, about this is just intriguing. You talked about other countries. Which countries are there? And they don't pay their physicians well. So what would happen then in that process? Would you be in this profession if you weren't paid fairly well compared to most people in America?
Personally, would I be in it? Yeah, absolutely. I love seeing patients. And I'll give you an example, Neil. It took a lot of courage 2 years ago to quit my job.
Yeah.
I quit my job because it was a toxic work environment. My pay went from X to 0 in an instant. And I'm still doing some clinical work now. Would I still be a physician if I was paid less? Yes. I think you have to look at, though, there's a couple factors when we talk about physician pay. It has not kept up with inflation at all. And so the golden era of being a physician and getting rich off of it that's long gone. Okay. And people are saddled with debt. Many of my colleagues can't walk away from their careers because they can't pay back their student loans. So I think that's part of it, but I want to digress a little bit in terms of talking about the middleman or the middle person or whatever. If you look at the late 70s compared to where we're at now, in a comparison of physician increase to administrative increase, there is a 20x difference in administrative increase versus physicians. So we have 20 times the amount of people between the physician and the patient that are sucking out money from the system. The money isn't going to where it needs to go in terms of delivering care. Money going to shareholders of corporations as opposed to actually delivering medications is problematic. It's incredibly problematic. And this is just the tip of the iceberg. I'm not an economist, and so I don't want to get out of my lane too much here, but I think you get the idea that there is a lot of fat in the U.S. healthcare system, if that makes sense.
Neil, can you imagine, you talk about what you get paid? My best man, John, who was on the show before, his father was an orthopedic surgeon. And I remember talking to him during residency in the 90s about what his father made as a physician, as an orthopedist. And we make less dollar for dollar than those guys made 30 years ago. So if they made $100,000 a year, we're making about 70,000 right now, not even considering cost of living, not even considering inflation, dollar for dollar. No one would put up with continuous pay cuts, no cost of living increase, zero. You agree with that, Todd?
100%. And I think your statistic there about spot on. It is, if you were to start to look at the comparisons of pay from physicians from 10 to 20 years ago to now, it is a downward trajectory. It's super problematic. Yeah, physicians are paid well, comparatively speaking, but as we talked about all those other factors, there are reasons for that. If you told a 20-year-old, hey, you got to go to school for 15 years, you're going to be saddled with $250,000 in debt, and when you get out, we're going to pay you $100,000. You have just eliminated a huge portion of potential eligible candidates.
That's true.
You're just said, hey.
And unless you have your own private practice in this specialty, that's the only way you can really make a lot of money as a physician, it sounds, correct?
There are lots of ways to do it, and we could probably go on the weeds. I'd like to give you an example, though, of a pediatrician who was trying to provide care in a lower income area and to keep her clinic open so she could keep paying her bills and pay her staff. She took out a second mortgage on her home. Is that what we're trying to do in this country? That's insane. And that's not an isolated story. There are stories of physicians getting crushed financially who are just trying to care for people. That's all.
Wow. So there's and is all this stuff in the documentary, what you're talking about, Todd?
In some facet
in your book and the documentary.
Yeah, if you follow me along, I talk about all this stuff all the time. I think the interesting part of a documentary about fixing healthcare, quote unquote, is it is a massive topic with a bazillion rabbit holes. And ultimately, truly, this is a project where you are building the airplane as you are flying it. But to the person who is going to hopefully see the project when it's finished, you are going to hear stories from physicians, nurses, patients, administrators, healthcare executives, celebrities about the current state of affairs and frankly, how the almighty dollar is killing people. Flat out.
I'm going to ask the same question to Jack. Jack, would you, Dr. Jack, would you work if you weren't paid as well as a physician, like we're looking at other countries and stuff?
Yeah, I would say the same thing. And it's, when I started, even during my residency, when I was working those hours, I was literally making less than $5 an hour. This was with an MD. And minimum wage at the time was $4.25. This is all in my book. I go through some of those details in my book. He was making, minimum wage was $4.25 in 1992, and I was making $4.75, maybe $4.95. But I said in the book, I loved it. Every day I was king of the world. To be able to do the procedures that I do, to be able to treat patients and have those victories is fantastic. But year after year, the administrative burden has gone up. The chores had gone up. Like you said, can't the billing company do that? Can't this and that? Sure, if there was a billing, most of the time you're doing there used to be transcriptionists. You'd see a patient, you'd have your little recorder, you dictate your note, and then a transcriptionist would put it in. Now we're the transcriptionists. Now we're also the billers, the coders. We got to look up codes for everything we do. And with the ICD, it's gone up, ICD-10. What is it? 70,000 different codes are in the new edition. How do you keep up with that? And back in the day, we used to have frequent physician meetings, M&M meetings, daily lunch meetings where you'd talk about cases and this and that. We don't do any of that anymore. Very little. I get that at the administrative university level. For me, my burnout episode when I was in Pennsylvania, and I was killing it. I was killing it in Pennsylvania. And I was coming back from Bedford, Pennsylvania. I was working a clinic down there. And as I'm driving north on I-99, I get a text message with a photo of this hamburger on the end of someone's leg. Motorcycle accident at 5, 6 o'clock at night, looking to get home, see the kids, have some dinner. And instead I get this photo, and it was like, for me, I can remember that drive like it was yesterday. It was like someone took my spine and snapped it. You know, it was just that. And then you get up there and, you know, like I said, then you love doing the job. And there's always that joy of putting someone back together. But then, like Todd was saying, and then your note is missing one little click box, and someone's going to dock your salary because you didn't click that box after you just saved the guy's leg.
Yeah.
They don't really care. They want the billing done first. So you can't not get burned out. It's just a matter of time. If you're in this field for long enough, kicking butt and doing your best for a long enough period of time, you're going to burn out.
And, you know, Neil, I think, if I may, I think we can't forget that the vast majority of people who go into healthcare, whether it's physicians, nurses, or whatever, it's a calling. You know, many of those people, they go into it because they want to help other human beings get to the end game. And then there's a survival fallacy like, oh my goodness, this isn't what I signed up for. And I'll give you just a simple example. I have a t-shirt that my buddy made up for me that it says, I wish I had it in front of me. It says MD equals professional box checker.
Yeah. That's the moral injury that happens. Yeah, you want to help patients, but before you can help patients, you got to call the insurance company. You got to do this. You got to do that. And then the electronic medical records are a disaster. I don't think there's any other industry that would tolerate the redundancy, the number of clicks, the inefficiency of an electronic medical record is you spend more time on the computer than you do with patients.
Would you want your commercial airline pilot charting while they're flying the plane or landing?
No. Yeah.
Would you? No, not at all. I make the example in A Ripple of Change. I talk about a commercial airline pilot where they're the pilot, the navigator, the refueler, the steward or the stewardess. And oh, by the way, they're charting all this at the same time. That's what we created out of our physicians and other colleagues.
Yeah. So Todd, now you're looking for what stage are you with the documentary? Are you currently filming, have already filmed part of it? Go into a little bit about that, because that's interesting to me, how you've turned your book. And when did you write the book, and when did you start the documentary?
Oh, sure. So the book was published in May of 2023. And that really led me on. I was on an interesting networking and advocacy journey because I stepped away from my former employer, made a bunch of connections, including Mary Ann Wilbur. It was her dream to create the documentary. And so where we're at with the documentary now is we have about a 35-minute piece that is essentially talking heads, dropping truth bombs that we showed in Detroit last month. Very well received. We anticipate a final product in November-ish, plus or minus. In terms of where we're at with filming, the vast majority of the interviews have been done. We've got a couple more that we need to do. What we're getting now is how do I say this? And I feel maybe awkward saying it, that sex appeal. What grabs the person to want to keep watching it, the B-roll, the graphics, all those kinds of things. So the story, the bones of the story, Jack, and I guess that's appropriate, the bones of the story are there, and we're putting all the meat and everything else around it. So that's where we're at. It's just been an amazing process too. And I think the thing that really gives me hope as we go through this, Jack, is people are ready to get involved. People are ready to do something. They want to be a part of change. And these people are all over the place. And a big part of the call to action of the film is really twofold. One, we want people to unlearn learned helplessness, because that's pervasive, that feeling that I'm only one person, I'm only one voice. What does it matter? I'll just give up. But really, the second part is around solidarity and bringing people together to move upstream, as Neil said, because we know we need policy change. We know we need legislators helping us. So yeah, that was a very short answer to the question of book, May of 2023, fun networking advocacy journey, causing trouble, pushing buttons, so on and so forth, to now we're working on the documentary with a target of November, plus or minus.
Very good stuff, Jack. Anything else to add? Jack, are you there? I guess you froze. I said you froze for a second. Anything else to add, Jack? Froze. The internet went crazy. So let's go back to you, Todd. So I guess what is the ultimate?
I'm looking.
Yeah. Don't worry. I'll just keep going. What is the ultimate goal? Now you're back. It seems like your internet's faster. Todd, what is the ultimate goal you want to attain in the documentary?
I joke that I want to boil the ocean when it comes to fixing healthcare, which I realize I can't do alone. But with a aggregation of enough voices, we can potentially do that. And I don't want to give away the whole thing, but think of an impact network and the power behind an impact network and what it can accomplish. That is a big part of what we're trying to accomplish with the documentary in particular.
Okay.
Right. I wish you luck, Todd. It's a monumentous task that you're undertaking here. I don't know how you have the time for it all. I'm sure you've got a lot of support, a lot of people that you're working with, but God bless you for doing it.
Well, I appreciate this opportunity too, Jack, and Neil. It was great to meet you. I will say this, with the way we set this up, there's a company behind this, and the threshold for joining is not high. We have about 60 organizations that have got on board, including 3 state medical, probably now 4 state medical associations, the American Academy of Emergency Medicine. I just talked with the former CEO of the American Nursing Association yesterday, who's going to connect me with some other nursing orgs. So if either of you want to join the party, you just got to let me know and I'll send you some information. Love to have it.
Yeah. You sent me that last week, so take a look at it.
Yeah. So some really big things coming up for you, and I'm rooting for you for sure.
Yeah. So how do people get a hold of you, Todd? If they want to get a hold of you, if they want to contact you, I know I saw you on LinkedIn. That's how we met. What other ways can people get a hold of you, and tell us your websites and all that?
Yeah, sure. So I'm very responsive on LinkedIn. I just look up Todd R. Otten, think rotten without the R, and you'll find me. And then website for the book is rippleofchange.us. And then the website for the documentary is suckitupbuttercupfilm.com. So yeah, any of those avenues, there's mechanisms to send me an email, but LinkedIn's probably the best way to get a hold of me as an individual. Love to hear from you.
Right.
All right. We appreciate it. And thanks again. It was a great conversation, Todd. All right. That's a special. You go to the ultimatemensmovement.com to schedule a call with Dr. Jack today. All right. That was a special simulcast of the Neil Haley Show and the Ultimate Men's Movement podcast, guys. Take care.